All right.
All right. I've stopped my share and over to you, Felice.
Okay, can you see my presentation? Yes?
No, I can't.
Yes.
Oh, yeah, okay. So I will present two cases, and both of them, they have something to do with CSF, so interesting. And we have also surgical video that Robert will comment.
Guys, I cannot see the presentation. So
I can see it. Can you see it, Amy?
Yeah, I think that was his title slide. He put our faculty slide as the title slide.
Okay, sorry. Okay.
So now we're into case one.
Okay, good.
Right, so this is the first case. It's a 2-year-old boy who failed the neonatal evoked autoacoustic emission test only on the right here. So he basically had severe sensory neural hearing loss on the right that was confirmed. But during the process of investigating his hearing loss, so before any images was available, he developed 2 episodes of bacterial meningitis. And this was quite interesting. And before imaging, we did tympanometry that showed flat type B trace on the right. Finding indicating right middle ear effusion, while on the other side, everything was normal. So we have 2 problems on the right, probably related to the inner ear, but also to the middle ear. So let's see some images. As you can see from my background, I'm trying to promote not only TBone, but also south of Italy as like vacation possibility if you want. And let's start with the first case. So let's start with the MR. So basically, this was an external MRI. So they did a brain MRI plus a high resolution T2 of the inner ear. And first things on the T2, you can see the difference between the left inner ear and the right inner ear, which is clearly dysplastic. Now, try to think how you will classify this malformation, this dysplasia. And of course, there is a lot of fluid in the mastoid and tympanic cavity. I think that is very important. It will be even more important if I can move this, is here that you can see basically the ossicles as a negative hypointensity within the fluid. On the other side, the normal side, we cannot see the ossicle. Now, if we go to the Fiesta, so high resolution steady state, I zoomed already in the at the level of the malformation. This was not the best scan, but it's enough for us to see that this is a cochlea that has 2 fundamental characteristics. First of all, the size is normal. It's different from the cochlear hypoplasia that I showed you last time. But in the cochlea, there is no internal structure whatsoever, and there is quite direct contact without the base of modulus between the cochlea and the internal auditory canal. The vestibule is enlarged. The lateral semicircular canal is small and dysplastic. The other canal are slightly dysplastic maybe, but not as much as the lateral. And again, we can see the hypointensity of the ossicles, not only the malleolus and the incus, but look at the stapes here. You see these 2 small areas of hypointensity. This is anterior and posterior crus of the stapes. So this is the stapes, but look, normally the stapes should go into the oval window, which here is quite enlarged. So there is quite a gap beyond the limit of the foot plate of the stapes. So of course, when you have all these bones involved, you don't want to rely on the MR only, so we did CT. So first of all, I discussed with Robert, and then as always, when we have these complicated cases, and then we did a CT that confirmed the malformation. And I can tell you that I will classify, despite sometimes types of inner ear dysplasias are a spectrum. So sometimes it's difficult to classify them. This we decided to classify as incomplete partition type 1 because we could see the separation between the vestibule here and the cochlea here. It's not completely wrong to call it common cavity, but again, this is a spectrum. And again, you can see here the stapes, and look how large is the oval window. Again, the middle ear is full of fluid, and you can see the ossicle here. So again, remember, this is a child with meningitis. Now, I will show you the video, and Rob can comment on it. Two videos, actually. Rob?
So yeah, of course, for IP1's CSF leak through the oval window is classically described, particularly those that have a large connection between the IAM and the inner ear. And this combined with the shape of the stapes means that you're very likely to have CSF leak. And you can see on this case, you've got a very, 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 very mobile stapes, which is flapping back and forth with the pulsation of CSF coming from the IAC and the intracranial cavity. So for cases like this, it's particularly crucial to get a good seal, a good closure of that leak, broadly speaking, which requires removing the entire body of the stapes in order to get adequate access to this. Obviously, that has a significant implication for hearing, but obviously this patient had no auditory nerve on this side, which made decision-making much more straightforward. And so in this case, I've achieved a complete seal by packing the area with fascia and then testing the patient, which obviously the video doesn't show entirely, but putting the patient head down, asking anaesthetic colleagues to do a Valsalva maneuver to put the repair under as much pressure as possible. And then subsequently for this patient, I've reinforced that with fibrin glue and by obliterating the eustachian tube with fascia, cartilage and bone wax, and then obliterating the entire middle ear space and removing the ear canal and doing a blind sac closure. Obviously, the interesting ones for these are those that have, or the most interesting ones are those that have a auditory nerve. And then if you're fortunate enough to be in a nation where unilateral hearing loss cochlear implantation is funded, then you can consider putting a cochlear implant in at the same time. I think putting it in at the same time is going to be worthwhile because you only want to deal with a CSF leak once, even if it's in two different areas.
Thank you very much. This was very nice. So this was an oval window perilimb fistula in a child with recurrent meningitis and unilateral incomplete partition type 1. As Robert said, we could not see the cochlear nerve, despite most of the incomplete partition type 1, they have the cochlear nerve on images. And autogenic CSF leak consists of an abnormal connection between the middle and inner ear, so the perilimb leak, but also because of the incomplete partitioning, we have abnormal and persistent connection between the CSF and the inner ear. And we have the CSF leak, so that is more frequent in patients with malformed inner ear, and recurrent bacterial meningitis can be associated with defect in the skull base, in anterior lateral skull base, causing CSF leak. So if you have recurrent meningitis and a diagnosis of unilateral malformation of the inner ear, think of a CSF leak. This is another case just to show you the typical appearance of incomplete partition type 1. So the cochlea has normal side, is clearly separated from the vestibule, but basically there is no internal structure, and this is the CT. In this case, differently from our case, we have the facial, the 8th nerve, and both the division. So this is incomplete partition type 1. This is just to show you the drawing in comparison to a normal cochlea here, and histological specimens that show that some of them, they can have the base of the modulus preserved, some of them no. And sometimes you can see the modulus here if you have a good MR when it's complete or incomplete. This is from a beautiful paper on inner ear dysplasias from Joshi, while these images are from this paper that is by Senarovi. So let's go to the case 2.
So,
Yeah.
Felice, before we move on to case 2, there are a couple of comments and questions here. So
Yeah.
from Asha Farmer, she had a question about the terminology. So one of the issues here is that with Dr. Senaroglu's existing classification, this would be called an IP1, but as we think of IP1s, there seems to be quite a range of anomalies from those with some external morphology to those with none. And so what we've been doing is we call the ones like your first example, a cystic cochlear vestibular anomaly, recognizing that it's somewhere in the spectrum between a common cavity and between the more defined versions of IP1. So you think that's acceptable?
Yeah, absolutely. This is actually, so the difference between IP3 and IP2 that are probably genetically determined is that IP1 and common cavity are probably due, at least this is the theory, to a abnormal blood supply from the internal auditory meatus during the development. So in this case, actually, we label as IP1, but this is really in the middle. We could see some separation, but the internal auditory canal was going actually between the two. So it's really a spectrum. The important thing for me is to evaluate the internal structure of the cochlea, which in this case was obviously complete absent, and also to separate this from the IP2 and the IP3 that seems to be etiopathogenetically different.
Absolutely. So again, it's a hybrid classification where IP2, IP3 have underlying genetic mutations. IP1 is more of a descriptive term without alluding to the genetic mutation. And from a clinical concern, the risk of both Palin fistula and stapes gusher, as somebody else, Victor Suarez was asking, he said, is stapes gusher to be expected? And absolutely, once you see the deficient medalis, lack of internal fixation, some cochlear turns, or total lack of internal structure, then presumably that is a concern.
Yeah. So yeah, that's very interesting. And another thing to remember is the difference between a cochlear hypoplasia, that there's a cochlea that stopped during the development and that can have or not abnormality in the internal partitioning, in comparison to the incomplete partition type 1 to 3, that by definition they have a normal size. So the development was normal in terms of size, but abnormal in terms of internal partition. So probably blood again during, is a theory, during the development coming from the internal auditory canal. The case 2 is also very, very interesting. It is a case where I was wrong, or at least I didn't expect was what Rob will show you. In this case, I will show you, the history, 4 years old girl. And this is really a long-standing history. She was 7 months old when she started to have pain, swelling, and redness in the right periauricular region, was treated with antibiotics, and they found that she has some CSF leak from the nose with this constant period of resolution followed by inflammation. So let's see some images. So the first image I would like to show you is a CT, and then I will show you the external MR and our MR. So this, you can see this appearance of, so this is the abnormal side on the right versus the normal side on the left. Let's start from the Otic capsule. Look at the lateral semicircular canal, is blurred. There is this a sort of blurring due to erosion basically of the bone. In a context of an infection, we think of a scalp-based infection. Look at the condyle in comparison to the left side is abnormal. There's involvement of the sphenoid body and wing. And again, this is quite interesting because this looks like in a condition of infection, a labyrinthitis by definition, but this is a labyrinthitis not due to hematogenic spread, but to the direct involvement of the bone. So this was very, very interesting. The rest was fine. The first MR that we received was an external MR, and they did basically, I will show you the T2, they did a brain scan. Now it's important that despite this is a brain scan, you can see the difference here in the petrous apex, again, Otic capsule between the right side and the left. Again, look at the condyle. And also occipital region, but because you have the signal, the hyperintense signal of the fat in your way, this is quite difficult to interpret in terms of extension of the abnormality. We had also a Fiesta that shows again some abnormality in the lateral semicircular canal, but the rest is fine. This is brain tissue here. And again, you can see the hyperintensity in the condyle. Finally, we did a proper skull-based scan, meaning that we added fat-saturated T2 sequences. The experts of head and neck, they don't use fat-saturated T2 in all the cases, but probably for the skull-based, it is really useful, especially in this clinical context. Look at the extension of this fluid on this side. Again, look at the involvement of the apex. That is very important every time you suspect a petrous epicitis by the clinical point of view, and the involvement of the sphenoid. Now, if we look at the fat-saturated post-contrast T1, you can see that actually there is enhancement, but it's a bit less diffuse than this fluid, especially in the apex. So the inflammation seems to be more fluid than actually enhancing. I didn't notice this difference before speaking with Rob in the post-operative, looking at the post-operative images that, and he will speak about the intraoperative video that he did, and that's it.
So with widespread skull-based changes like this, obviously we think of a number of things it could be, but I think obviously this is was a very difficult case to manage. They were an international referral, so we hadn't seen them until they were some years into their clinical course. And broadly speaking, it seems as though they've been having episodes of periauricular infection, which have broadly speaking had limited treatment. Now, whether or not this represented just a chronic or resolved osteomyelitis, or whether there's some kind of an infiltrative or bony metabolic condition was unclear. And so surgery was predominantly to get a biopsy and get diagnosis and see if we could culture any viable organisms. Now, as you can see from the surgery, really as soon as the periosteum is taken off the bone, you can see that you've got leakage of CSF really throughout the temporal bone. You can see leakage through holes in the ear canal, leakage into the middle ear, posterior, superior to the cortical mastoidectomy, even from the mastoid tip, and this video shows that. So this essentially is just the very long-term sequelae of having chronic or multiple episodes of osteomyelitis, which have really destroyed a lot of the temporal bone on this side and haven't been adequately treated quickly enough, as it were. And so the temporal bone has very little viable or intact tissue on this side, really. The management of this case is, or these cases, is particularly challenging. Obviously, you want to do as little as possible because surgical management of these, there's no way to completely close all the CSF that's leaking throughout the temporal bone. So you have to be really sure about where the CSF leak is coming from. because surgery, for example, to close this would be in the form of free tissue transfer and so on, or complete obliteration of the ear in an ear which is actually working normally, hearing normally. Consideration for these cases is really quite difficult.
Thank you.
So this is really fascinating. You're going to see an uncannily similar case in my first case that I will show, and it may actually provide an answer as to what's going on in your case.
Amazing. We're looking forward. So this is our case, and just wanted to show some slides in terms of involvement of the petrous apex. So this we consider radiologically a petrous apicitis. Of course, we have a lot of lesion in the apex. This is something very common. Of course, when I was a resident and I saw some signal like that, it looked like that, but actually this is just fat. You don't need the fat saturated. It's very typical leave me alone lesion. But in this case, we had fat saturated confirming the fact that there was just fat. But we also have fluid. In this case, it's just another leave me alone lesion. So this is a fusion of the petrous apex. If you have a CT, this lesion will not have any erosion, but you sometimes can have some erosion in the petrous apex, like in this case that Lorenzo Pinelli gave to me, showing also hyperintense signal in T2 and T1, and this was a cholesterol granuloma that needed follow-up. Another involvement, infective involvement of the petrous apex as a consequence of bacterial meningitis. You can see here the meningitis. You can see the fluid and the inflammation along the skull base, also involving here the nerves. But here there is a part that does not show enhancement. This is another case, patient from Rob. And you see in diffusion, you have actually diffusion restriction at this level. So this radiologically was interpreted as a petrous bone, a petrous apex abscess, which is very, very serious situation. So remember that petrous apex has important complex relationship with important structure like cavernous sinus, dural canal, Meckel's cave, and you have a lot of leave me alone lesion like not only a fusion or fat, but also encephalocele. You can have cholesterol granuloma that shows hyperintensity in T1 and T2 and can have this rim. This is from a book, rim areas of T2 hypointensity because of the bleedings. And look for complication like cavernous sinus thrombosis. And we have a couple of cases were very difficult to manage. Of course, you can have cholesteatoma also in the petrous apex, but remember that cholesteatoma will show diffusion restriction. This is Amalfi Coast, and if there is any question, I hope you like these cases.
Callie,
Fantastic, really amazing. Yes.
Callie, there's a question about, I guess for both of you is, were bone biopsies taken?
Yeah, so the purpose of surgery essentially was to take biopsy to rule out, well, to rule out infiltrative disease, to rule out bony metabolic disease, and to look for active organisms. As I say, it's a slightly strange case because they'd been treated abroad for about 4 years. They're not a UK national, and so they came to us really quite far down the line of the condition and had a number of investigations. In fact, I think they even had a radiolabel white cell scan overseas. But no, in the end, we didn't isolate any organism, and the biopsies didn't reveal Gorham-Stout disease. I know that's what one person's asking about. But yeah, so it's just the consequences of chronic osteomyelitis, essentially.
Amy, you're next. So.
Yep. Okay, let me look for my PowerPoint and I will share my screen. Hello, everybody. Thank you for joining us from far and wide. It's always exciting to be here with all of you. to discuss interesting cases. So I have 2 cases to show today, and I have a few companion cases for each. All right, so here's my first case, a 30-year-old female with conductive hearing loss. Okay, so I have an image for the right and an image for the left, axial images. So as you can see here, there is this abnormal hypodensity in the Otic capsule that's in the area anterior to the oval window. And it's a little bit expansile, and the stapes foot plate itself is also a bit thick. Similar appearance on the left, maybe a little bit less expansile, but similarly hypodense and in a similar region. So whenever you see something anterior to the oval window, people like to mention, oh, I know, it's in front of the oval window, in the region of the fistula antifenestrum. I'm going to think about otospongiosis or otosclerosis. So let's think about that and think about, could there be any other possibilities? So this is the same patient. These are coronal images. And as you can see, these hypodense areas are continuing down over the cochlear promontory, down the cochlear promontory. And one feature I want to point out is that this hypodensity really does go all the way out to the edge. And you don't see any more normal white bone, dense bone on the other side of it. So it's right up to the edge, and it's liking and going along the cochlear promontory. So here I have 2 video clips, just so we can see this. On the right side, again, that abnormal hypodensity, and not too much elsewhere, maybe a little bit around the cochlea. I don't know if this will pause. Yeah, maybe a little bit right around here, but a little farther away from the cochlea. So similar on the right, on the left side, there is this hypodensity and not too much elsewhere. But I do want to point out that there is maybe a bit of hypodensity around the facial nerve canal, and it is a bit expanded, and it goes down the promontory. All right, so what is the differential diagnosis? Well, we already mentioned one thing, which is otospongiosis, so that's certainly a consideration. They can expand and thicken bone towards the sclerotic phase, so that's okay. You would like for it to be conforming to the embryology of the Otic capsule, where there's an outer layer that's not affected, although that's microscopic, but we should think about some other things. So let's take a look. So lytic change or demineralization in the Otic capsule. Okay, so here is a list that would be a good differential to keep in mind. Otospongiosis, which we talked about, osteogenesis imperfecta, otosyphilis, and Paget. So all of these entities are often bilateral. They can be asymmetric. Sometimes they can look unilateral because the other side is not quite affected yet, but they can be bilateral entities. All right, so let's look at a different case. So here's a different patient. And here is the right temporal bone. You can see this lucency going around the Otic capsule, around the cochlea. And I want to point out how there is this denser bone on the outer side of it. This is going towards the anterior aspect of the IAC, towards that quote-unquote notch, which is much debated whether this is a feature or not of the disease. But here again, here's the notch. You see that ring, and there's a bit of preserved bone on the outer side of it. Continuing down, again, see that normal-ish sort of denser bone on the outer side of the hypodensity. And here is the coronal, where you can see, unlike the earlier case, which was the case I was showing, as opposed to this companion case, on this companion case, you do see that denser white line on the outer side of it. On and the disease is bilateral, and the patient actually had a cochlear implant on the left. And as you look up towards the semicircular canal, so you see this abnormal hypodensity that goes quite all the way, almost right up to the semicircular canal on both these images. Okay, so I just want to spend a little bit talking about the bony labyrinth and with the entity of otospongiosis, which is what this companion case was. This is otospongiosis. So the bony labyrinth normally has 3 layers. So it's composed of the outer periosteal layer, which is this yellowish beige layer, and the inner side is the endosteal layer, which is thin here, and the middle is the endochondral layer. So Otospongiosis, otosclerosis, is a disease of the middle layer. It's not a disease of the entire otic capsule, not the outer layer, the inner. It's a disease of the middle layer of the otic capsule. And this is credit to Monique Cosby. I found this very useful picture on the internet. So then we can imagine, we know what the labyrinth looks like. So you would expect that otospongiosis can only affect geographically what's around what's shown here on this figure and nowhere else, because it is a disease of the middle layer of the otic capsule and has to follow the rules of embryology. Okay, so here is another patient, and the clip here shows, again, this abnormal lucency that looks like a halo, and it's following the rules. It's around the cochlea. The edges seem to be a little bit okay, and it goes all the way around the semicircular canals as well. Here is again that look, and I don't know why, I'm not sure it's exactly logical, but this really makes me think of, and this is like one of my favorite candies. You can't see this in a lot of stores, and this is like a very, I guess, American thing. I don't know if it's in Europe or Asia, but these are bullseyes, and I love it. These are like caramel creams, but you see that outer side should be okay, and it's a disease of what's inside that outer layer. Ideally, there should be like a middle one, that's the endosteal, that's not affected, kind of like a Swiss roll. But nevertheless, it's a disease of the middle layer. All right, so here's another companion case. So that one was otospongiosis. Now this one looks kind of messy. You see these areas of hypodensity? They're not really following any geography. Some of it maybe, you can say, oh, is it around the cochlea, you know, but this here is just really maybe a bit of it, but it's a little bit more extensive. And also the ossicles might be a little bit demineralized looking. So this is a case of otosyphilis, and we don't have so many because this is really not that common, but this is an article where they published the images, and you can see it looks very much like otospongiosis, but the features are that it fades away towards the outside. It's a lytic sort of process. And also it can lead to demineralization of the ossicles. And so the pathogenesis of hearing loss are a few. One is that you can actually have a meningitis from syphilitic meningitis that's affecting the 8th nerve in the IC. Another is that you can actually find spirochetes. You can find the treponemes inside the perilymph. So the organism is in the perilymph, and it leads to this inflammatory, incites an inflammatory reaction, and it leads to osteitis, and it leads to demineralization. So it just kind of destroys the bone around it, as opposed to otospongiosis, which is very specifically a certain layer of the otic capsule. So this is just mapped up so you can see the area where it fades out towards the side, away from towards the perilymph, and also you get demineralization of the ossicles. This paper, I believe, is actually out of Boston Children's Hospital, where Callie is, along with Finland. And here again, you can see that this is kind of messy. It's not following a ring, a halo, geography. It's just, you know, kind of here and there. And some of it is around the cochlea. So again, magged up, you can see this kind of, you know, look that's kind of moth-eaten, a little bit permeative, lytic, but not completely abiding by those nice rings and halos. Here's another case. This is a pediatric case from a vertical transmission, so it was congenital syphilis. And you can see that halo around the cochlea, but also the demineralization. So there ended up being conductive hearing loss was how the patient was presented. Here's another companion case, which is not otospongiosis, not otosyphilis, but this one, if I told you this was an older patient, you can see all the bone diffusely is all kind of coarsened and thickened. It is a bit hypodense, but this is a Paget disease. So this also does not only select out for the otic capsule, and certainly not the middle layer. It's all over, and it's coarse and diffuse. Here you can actually see it's going along the subarcuate canal below the rainbow of the superior semicircular canal. All right, so back to our original case. It does not look entirely like an otospongiosis. It could be those other entities, but this turned out to be an osteogenesis imperfecta type 1. So the osteogenesis imperfecta is a disorder genetically of collagen manufacturing problems, and it's collagen type 1. So it affects bone, just, you know, bone. And from the name, it's basically imperfect bone formation. So it's just any bone can be perfectly formed. It can be very diffuse. It can be very widespread. So it tends to be thick and expanded bone that's demineralized. And if it's near the stapes foot plate, it can lead to a conductive hearing loss, which was what this person had. And it tends to have this predilection for the cochlear promontory. Okay, so that's my first case. So the take home is basically it's a differential of, or how to think about otic capsule demineralization. So we should know the differential, otospongiosis, otosyphilis, Paget, and osteogenesis imperfecta. You could think about osteoradionecrosis. We've had a couple of cases, but those would not be bilateral. And typically you'd see some changes in the EAC, some changes maybe in the mandible and the TMJ area. Otospongiosis, remember, it has to obey the laws of embryology. It's that middle layer. I've seen enchondral written as well, but I checked with our pathologists, and they use the lexicon endochondral. And with OI, it's all bone. It somehow likes to go along the cochlear promontory. The bone is thick and under-mineralized. And otosyphilis is just permeative. It fades out towards the edges. And it does not like to go particularly around the fistula. And I say around, not of. Sometimes our trainees would say the fistula antifenestrum is hypodense, but that's not correct because embryologically, the fistula itself is actually a little cleft. So by definition, it's really the bone around that cleft. So it's the bone around the fistula that's abnormal. And Paget is diffuse and coarse. Okay, so that was my first case. And now, if no questions, we'll go on to the second case. 43-year-old male, history of chronic otitis media, with recent episode of infection associated with vertigo. And there was a conductive hearing loss, but with normal bone conduction thresholds. Okay, so this is a video clip. Scrolling through here. So you can see there are some problems already. The bone is not quite intact. There are areas that are a little bit chewed away, but the bone is kind of sclerotic also. So maybe this is kind of chronic. There's a chronic component, and bone is, frankly, in this case, destroyed, because on this image, you can see the entire lateral semicircular canal that's now completely surrounded by air. So it's skeletonized. The bone around either side of it is just completely destroyed. The tegmen is destroyed. There's no more good delineation from the intracranial compartment. The tympanic facial nerve over here is inseparable from the middle ear opacities. And you can see here in the superior semicircular canal, as you follow it up, there is now gas in it. So this erosion or destruction, frankly, is going all the way into the membranous labyrinth structures and skeletonizing things. So it's quite aggressive, this process. Okay, we look on the coronal image, which just offers a slightly different view. So again, we can see that tegmen is completely dehiscent and destroyed. We can see here is the tympanic facial nerve. It's coming right out towards the middle ear cavity and is hanging in the breeze and contiguous with this opacity. And you can see the air in the superior semicircular canal once I get to that. So here is one limb of the superior canal. As you scroll back, you get right into this air channel. So an aggressive lesion, it's frank destruction of the bone. So what is the differential? So earlier, Felice showed a case of that skull base infection that can lead to really quite aggressive destruction. So that would be a thought. So this patient did go on to get an MR, and you can see that on T2, it's kind of intermediate signal, but no enhancement on post-GAD. So it's not an aggressive tumor, for example. It's not like a squamous cell carcinoma. Also, the look on CT, it was kind of broken up, so it's not like one big chunk. And the bone around it is sclerotic, indicating there's some chronic component to it. So here again, it's non-enhancing. So we did check. We're like, what if this is an encephalocele? So we do these inversion recovery sequences, double inversion recovery. So some of our techs are on this call, and they know it's reflex. When we're looking for encephaloceles, we would run these sequences. So you can see on top, the fluid is black. So the black is great. It stands out really nicely away from brain parenchyma, so we can tell there's no brain in there. And just to confirm, we get it a different way. So the fluid is bright, and we can see there's no gray matter in that area. But instead, it's right on the coronal DWI. So, and I think recently this was just being tweeted around. Dr. Dufour had articles published indicating that the echoplanar imaging technique is not always optimal. So when we choose a non-echoplanar imaging, and especially the coronal plane, that really helps us in not getting fooled into false positives or false negatives. So this was a case of a cholesteatoma. So just to show that, you know, cholesteatoma, we see those all the time. It's not that exotic, but they can be really destructive, and they can go all the way into the semicircular canals. And it's okay when we see this to say, yes, this is consistent with a cholesteatoma. So just a couple more cases. On the left is one patient where the right temporal bone, you can see that there's this fistulization or erosion into the lateral canal. So oftentimes when we see a third window with a canal, it's a superior semicircular canal. They dehisce superiorly, sometimes towards the groove for the superior petrosal sinus. But when it's an erosion of the lateral canal, oftentimes it's because there's a cholesteatoma. This patient here, left temporal bone image, again, there's this soft tissue going towards the lateral semicircular canal. This is another case that is really quite dramatic. When you first see this, you would be worried for some really bad malignancy, which is certainly possible, just chewing and eating into the external auditory canal. But there's also an expansile component here in the petrous apex, and Felice again gave this wonderful differential on lesions in the petrous apex, including cholesterogranuloma, and so on. In this case, there is restricted diffusion, so this was a cholesteatoma that was very destructive. Okay, so that's my second case. And the first case was Otic capsule demineralization, how to think about it. In this case, it's Otic capsule frank destruction and how to think about it. So cholesteatoma is certainly possible, a bad malignancy is possible, and a skull base osteo, which is this case here. So you can see on this video where there is all this lytic bone destruction that's now contiguous with the cochlea, and there's opacity also in the middle ear cavity, into the mastoid, and there's all this enhancement that continues down towards the skull base, where here you can see involving the longest colli muscle. Okay, so those are my two cases.
Amy, there's a question from Felice, and he says, can you comment on the incomplete ossification of the Otic capsule seen in children, in particular the area of hypodensity in the bony island of the lateral semicircular canal? I guess he wants you to talk about the size of the bony island of the lateral semicircular canal.
Oh, the size of the bone island?
Yeah, I mean, is that what, Felice, is that your question? Sorry.
It's also that, you know, we know that there is incomplete encontral ossification around the cochlea sometimes, but I always see, and this has not been described as far as I know, some hypodensity in the bony island. So there is the semicircular canal, there is the density of the bone, and then there is another hypodensity that to me is completely incidental, but I wanted to know in the context of differential diagnosis of Otic capsule erosion, how you interpret that, or if you think can be pathological if you write down in the report.
Yeah, so I'm not sure about in the literature, but interestingly, the resident at MGH, who I think is on this webinar, and I and my co-worker and colleague, Catherine Reinshagen, we did work on an abstract where we were looking at density measurements of different areas around the Otic capsule, and we wanted a normative location to say, you know, what would be considered a normal-ish number so we can compare. And so at first we were like, oh, let's pick that bone island in the middle of the lateral canal. But it turns out that we run into the problem you're exactly describing, where it's smack in the middle. It tends to be a little bit less dense, but we see that in the control group. We see that in the group with disease. So I think maybe it's embryologic, kind of like the cochlear cleft, which, you know, has been described. So I don't attribute that to pathology necessarily. And so for otospongiosis, I just look at the areas elsewhere, but I have noticed the same thing you have, which is the right in the middle of it, it tends to be less dense. So we've had to move our baseline sort of normative comparison to a little bit off to the edge.
Great. I think in the interest of time, should we move on because it's 1:45?
Yeah, and one other quick question here from Shilpa Hedge. Would you include radiation osteonecrosis to your differential?
Yeah, so I mentioned how with the destruction or even with the demineralization, it could be from ORN, but as I think I mentioned, I'm not sure, you would see greater changes than just in the Otic capsule. So the EAC frequently would be fragmented and tunneling. That's a classic buzzwords for ORN, is the tunneling, the fragmentation, and the TMJ, the mandibular condyle, would often have some findings. So it would be, there hopefully would be some supportive evidence. But yes, ORN can certainly cause demineralization and erosion of the Otic capsule.
All right, so can you guys hear me or see my screen? Amy?
Yes.
Okay, great.
Thumbs up.
Okay, great. So, so this is our case. Hopefully this is going to be a relatively quick and easy one, but the history here was a 70-year-old person who had mixed hearing loss on the left side. So let's go on to look at the axial CT images on the right side. And just to recap the anatomy, you can see the ossicles here. You have the ice cream cone, which is the head of the malleus, and the body and short process of the incus. As we keep coming down, you can start seeing the crura of the stapes and the long process of the incus and the manubrium of the malleus coming up. And this is the incudiostepidial joint. Now, coming to the side of the abnormality, you can see that nicely seeing the ice cream cone at the level of the epitympanum. But as we keep coming down, and we still start seeing the stapes, the two crura of the stapes, but we never quite see the long process of the incus on the left side. So the other finding here is that there is evidence of some chronic otomastoiditis. There's sclerosis of the mastoid air cells, as well as the middle ear cavity. So if we go to the coronals, you can sort of see the same finding here. So as we scroll, let me bring up the long process of the incus on the right side. You can nicely see the long process of the incus and bending to the lenticular process. And on the left side, you really see nothing. It kind of stops short. It doesn't go down at all. So this is where I actually like seeing my sagittal obliques, because I think these sequences really help bring out the ossicles. So even though technically we do them for superior semicircular canal dehiscence, but I love these because you can see nicely on the normal side, this is the body long process of the incus, lenticular process, whereas on the abnormal side, it basically stops short. It's just, completely absent. So what we're dealing with is a resorption of the long process of the incus, which obviously it's an acicular abnormality, and so it can present with conductive hearing loss. So I did a bit of a deep dive into what this is. So there was this like classic movie from the 1960s, Peter Sellers, Stanley Kubrick. I don't know if there are any Kubrick fans in the house, but and I sort of came up with an alternate title, or How I Learned to Stop Worrying About the Pandemic and Love the Incus. So let's deep dive into the incus a little bit, shall we? So for this, I have to go back to this classic paper from 2009 by from our group at Mass Eye, which Amy knows all of these people, and Dr. Merchant was by far one of the brightest otologists that I knew. So they did a lot of histologic studies on the distal incus. And so they actually, so we think of on CT of the incus as a long process in the lenticular process, which articulates with the stapes. But when they actually did histology, and they found that the lenticular process is composed of two parts. So there's this skinny pedicle, and then there's a more flat plate-like structure. And that plate then articulates with the head of the stapes. So this, as a concept, was kind of radical because I had not thought of it that way. I always thought this whole thing was just one sort of one bony component. So, and they found that, yeah, so this is like a kind of a change in the way I thought of the incus and the lenticular process. And the other interesting thing is when they actually looked at it clinically during intraoperative evaluation, they didn't really see this pedicle as being like a skinny stalk-like structure. So in real life, it looks just like it's the same thickness as the long process, but in histology, it's actually a more skinny process. So they say that the theory is that because there is a thin pedicle and then there's a plate of the lenticular process, it sort of helps direct the motion of the incus more in this sort of piston-like fashion into the stapes, as opposed to, so it sort of absorbs the up, down, and other sort of motions of the incus, and just sort of encourages this more sideways motion of the stapes. So they suggested that there are two factors that contribute to the pathologic resorption of bone in this region. So one is that there's overall slenderness of the bony pedicle of the lenticular process, and that there's progressive loss of bone in that area with age. So, so this is a case of resorption of the long process of incus. And I've seen it in two settings. I mean, one setting is when you have some chronic inflammation of the middle ear and mastoid, or you can see it idiopathically where the mastoid looks completely clean. And in terms of the theory for why it happens, one theory is that there's actually, instead of having less number of vessels in this area actually has more vessels than normal. So this is actually a hypervascularized area of the incus, and somehow, for whatever reason, there tends to be this hyperemic resorption of this region, and it's not completely well understood as to why. And then there's also some theories about altered bony remodeling in this region from some mouse model data. So, which brings me to this paper by again our friend Dr. Giuliano. She is prolific, as we know. So, so Hugh and Catherine, Catherine was the first author, and they actually did a histology and a T-bone study on patient who had a resorption of the long process of the incus, and they actually confirmed the finding that in the patient with the hyperemic resorption, it was actually a process of the lenticular process. It was an abnormality of the lenticular process of the state of the incus. You can see that the pedicle is shortened. The plate looks relatively normal. So, so yeah, so just remember that lenticular process is not just that, a bend at the end of the long process. It's actually got these two little components, and, and they can, this is one of those things which I've seen missed a lot. So just be aware that when you have somebody who has conductive hearing loss and on your first pass through the temporal bone CT, you don't find anything, then you might want to go back and look at the long process of the incus. So, and this is actually more sort of, it's not just the long process. In this case, it's actually, it's not just the lenticular process, it's also the long process. So this is a much more striking example, but just something to be aware of. All right, so now moving on to our next case.
So, Gul, as you're getting your next case up, we also see cases in young kids without any preceding history of infection. And interestingly, one of our oral surgeons, Dr. Dennis Poe, says that when he palpates the incus at the time of surgery, if they're doing surgical exploration, the type that is destroyed as a result of infection will feel gravelly to palpation, and the type that is a developmental variant, which can be unilateral or bilateral and sometimes hereditary, the incus has a much more smooth contour to palpation. So important to be aware that this can occur as a developmental variant as well.
And it's symptomatic, Kelly, or is it like a incidental?
Yeah, absolutely.
Oh, okay.
Conductive hearing loss, very easy to miss if you rely on axial images. So really highlights the importance of looking for the entirety of the incus on coronal images.
Exactly, coronal or sagittal, yep. So this is my second case. This is more of a kind of a show and tell, but it was a pretty example. So I figured I'll show this. So this is a patient who has a bilateral sensorineural hearing loss. And you can see on this first image that there is definitely enhancing mass in the left IAC. And if I did not scroll this examination, obviously the first thought would be vestibular schwannoma. But as I scroll back and forth on this case, you start seeing additional abnormalities. You can see that there's enhancement of the trigeminal nerve on the right, and maybe a little bit of enhancement within the Meckel's cave, a nodular enhancement. And as we keep going forward, back, you can now start seeing that there's a much more large nodular enhancement within the brainstem and within the fourth ventricle. So this is, these are the coronal axial images, again, noting the intraventricular nodular enhancement, as well as nodular enhancement of the IAC, left greater than right, and additional nodular enhancing foci. So this is a sort of a classic. Also notice that the infundibulum is thickened. So this is pretty much a radiographic ant mini or classic study, but I just wanted to show it because it reiterates important points about this diagnosis. So also notice other sort of areas of nodular enhancement intracranially and along the ependymal surface. So this, you know, when we see that for trainees, you know, when you see nodular enhancement, leptomeningeal enhancement are, you know, sort of Pavlovian responses, lymphoma, sarcoid, TB, and then other infections, and you know, other granulomatous diseases. And so this is just a very good example of sarcoid. And you know, sometimes you can imagine that sarcoid can, you know, if you just saw this and you didn't see any of the other findings, you know, I would not think of sarcoid. But really, you have to start, you know, thinking of sarcoid in most differentials, you know, as we already do in radiology. This patient also had MRI of the thoracic spine, and you can see that there is some nodular leptomeningeal enhancement of the thoracic cord and some mild T2 signal abnormality also. So this is just a classic sort of IAC involvement of neurosarcoid. And I just had a few sort of companion cases with this, just, you know, quickly. I know that we're sort of running out of time here. So this is a patient who has a known diagnosis of sarcoid. And let me just bring this up, sorry. All right, so this patient had a known diagnosis of sarcoid of the nose. So you can see that there is definitely a sort of a small soft tissue mass here in the right nasal cavity with bony destruction. And this, you know, some thickening of the mucosa. And this was all sort of well known to the clinical team. However, as we were scrolling through the images, we also noticed that this patient had some abnormality in the left temporal lobe. You can see that there is some sort of nodular enhancement here in the left temporal lobe and maybe some cystic change. So long story short, we got an MR. And since we're all neuroradiologists, in addition to being head and neck radiologists, I figured this might be a good case to show. Here you can see that there is definite extensive nodular ependymal, subependymal, and parenchymal enhancement in this patient. There's a lot of edema and mass effect associated with it, not really much of a DWI abnormality. So this is also sort of, you know, a presentation of sarcoid that we should be aware of, and that is just like intraparenchymal or subependymal masses. And interestingly, we did get a MR spectro, and this just proves my theory about MR spectroscopy, is that it sort of can be positive in everything and nothing. So this is a case of a spectro which shows that you know, the choline was high on this side, on the left side, compared to the normal side, and the NA was low. So, you know, sarcoid is the great mimic. This was a case from yesterday, which was so pretty that I had to show this. Even again, another sarcoid case, but I just had to show something that was pretty classic. So let me just show. So this is a person who has sort of known neurosarcoid. And so he presented with seizures, and look at this. So this is exquisite example of nodular leptomeningeal enhancement in the left frontal lobe. And also notice that there is some nodular enhancement along the perivascular spaces here. And when you see this, this is pretty much classic for sarcoid. So my second case has been a spin-off. I showed you IAC neurosarcoid. I showed you some nasal sarcoid and brain sarcoid, presenting both as leptomeningeal enhancement and also as an intraparenchymal mass. Thank you.
Thanks, Doll. So if you end your share, I'll share my screen. And so in the few minutes remaining, I'm going to pick up from where we left off a couple of weeks ago, and also, in fact, in relation to some of the cases today. So the first case is going to highlight a differential for IAC masses that now includes pseudomass. We'll consider benign differential for petrous apex lesions and for geniculate DM that Amy showed. And lastly, which cases do you dread most on service? Well, for me, it's the postoperative cases. So that's going to be case 2. So starting off with our first patient, this was a young boy who had a history of pneumococcal meningitis as a toddler, and then went on to develop sensorineural hearing loss. And he had outside imaging and had repeat imaging in our institution. And our oral surgeons visited the reading room and had a few questions. So they wanted to know, first of all, did we think there was an IAC mass? And if so, what was the mass? Secondly, what did we think was going on with the geniculate ganglion? Thirdly, considering that they were planning to operate, were there any vital structures that were involved in this process? And finally, they wanted to know whether we thought there was any reason apparent on imaging as to why this patient had had meningitis. So if we look at the imaging, and starting off with the MR, and if we scroll through to the top of the stack of images, you can see that regarding the first question about the IAC mass, that what appears at first glance to be a nodular mass along the cranial nerve is in fact a little protrusion of the patient's very own flocculus, which has herniated into the IAC. As you look at the IAC, you can see it's abnormally widened on the right, and that CSF signal abnormality is going all the way along from the IAC into this expanded facial nerve canal along the labyrinthine and geniculate portions. And in this patient, there is also a microcystic appearing abnormality involving the petrous apex. As we scroll down, the abnormality affecting the facial nerve, CSF signal intensity, extends into the middle ear space. And interestingly, there is a second protrusion of CSF signal intensity along the pars nervosa of the jugular foramen. And again, more microcystic signal abnormality involving not only the petrous apex, but also the basal occiput. Now, as we look at the accompanying CT, you can now appreciate the similarities to the case that Felice showed as his second case. So there is essentially a meningocele extending through the IAC to involve the facial nerve canal. There is erosion and remodeling, very sharply marginated remodeling of the right petrous apex. But that the fundamental problem in this patient is that the bone itself is abnormal. And this abnormality involves both the petrous apex and the basal occiput. Now, in terms of what we think this is, well, our presumption is one of two things. One is the bone is abnormal because of an underlying low flow vascular anomaly. The fluid within these spaces does not enhance, so we thought it was a lymphatic malformation. Or two is the same question as Felice's group had: could this have been a long-standing erosive osteomyelitis that had been neglected and ultimately led to these secondary meningoceles? In terms of vital structures, very concerning was erosion of the carotid canal, as seen here on both sides. And also the carotid canal could be seen protruding into the middle ear space. And then, of course, the concern for the meningocele surrounding the facial nerve canal. So interestingly, this otoscopic video from Dennis Poe actually shows the carotid artery pulsating against the tympanic membrane. This patient ultimately underwent surgery to address the recurrent CSF leaks and trying to perform a duroplasty to prevent recurrence of meningitis. At the time of surgery, they did perform biopsies of bone, but the past report that came back was that the biopsies were too small to confidently evaluate for underlying lymphatic malformation, but that there was no evidence of any infection, no organism was found, and there were scant inflammatory cells. So the presumption is that this was most likely an underlying skull-based lymphatic malformation that had led to a CSF leak. Well, it turns out we've seen this in at least 2 other patients. Here is another one with a petrous apex meningocele, erosion of the carotid canal, and once again the bone surrounding the middle ear space, extending laterally towards the temporomandibular joint, was all abnormal both on CT and MR. And this patient was felt to have had a meningocele developing in response to bone that was fundamentally abnormal to begin with. Now, when it comes to petrous apex cephaloceles, these are uncommonly encountered, and they can be either completely asymptomatic or be associated with recurrent meningitis. Here is an example of a patient with what is known as a cephalocele of the petrous apex along Meckel's cave that is really thought to be a form of arachnoid cysts that then presents on imaging as a cephalocele. Oftentimes, these may be asymptomatic, but again, there is a risk of meningitis. As opposed to this patient who has an underlying diagnosis of NF1, and you can also see cephaloceles in patients with an underlying diagnosis of mucopolysaccharidosis. And then we see bilateral cephaloceles and widening of skull-based foramina in response to chronic raised intracranial pressure, particularly in the setting of disseminated tumor, as in this patient who had a disseminated histiocytic tumor, when not only is there raised intracranial pressure, but there is also a CSF resorptive problem as well. As Felice mentioned, do not mistake benign, leave me alone, petrous apex lesions such as pneumatization variants for erosive lesions. We do periodically see sharply demarcated erosion with a characteristic lesion that is bright on fat suppressed T1 as a manifestation of cholesterol granuloma. Unlike the preceding entity, there is an erosion of bone and it's expansile. The petrous apex pneumatization variants are typically asymptomatic, non-expansile, and they do not erode the contours of the bone. Okay, so moving on to the second case. So John Doe says cephalocele or meningocele. So good question. We actually say that the most appropriate term to use is cephalocele, and cephalocele then allows you a little bit of leeway as to whether it's pure CSF, as in a meningocele, or CSF plus neural content, in which case it would be a meningoencephalocele. So a generic descriptive term would be cephalocele, and it's absolutely fine to call it meningocele if you think it's really only CSF intent. Okay, so that's that for there. And then this is the second case. So this patient is a 12-year-old female who had intermittent left ear drainage and conductive hearing loss. And the CT showed poor mastoid pneumatization with surrounding sclerosis, opacification of all mastoid air cells, and middle ear space opacification with erosion of the stapedial capitulum and of the short process of the incus. And then the coronal images show displacement of the eroded ossicles and blunting of the scutum, which enables you to confidently suggest that this is pars flaccida or acquired cholesteatoma. So no mystery with the preoperative diagnosis. So when it comes to postoperative follow-up, we perform oftentimes a combination of CT and MR. And this patient underwent MR, which showed a rounded lesion on T2 space, which had decreased diffusivity on non-EPI resolved diffusion-weighted images. So we suggested recurrent cholesteatoma, and for this first case, the finding was confirmed at surgery, recurrent cholesteatoma. However, second case is of a similar history and finding, again, diffuse opacification under pneumatized sclerotic mastoid, ossicular erosion, displacement, blunting of scutum, pars flaccida cholesteatoma. Patient underwent a mastoidectomy with canal wall up procedure and total ossicular reconstruction prosthesis. So our concern was the angulation of the prosthesis and the degree of opacification, and then thirdly, the defect in the mastoid tegment. So this patient underwent an MR, and MR was helpful in discriminating between fluid signal intensity as opposed to this component in the mastoid bowl, which looked more hyperintense on T2 and had a small focus of decreased diffusivity, but also a fairly sizable component that was bright on T1. So this was read out as possible recurrent cholesteatoma together with cholesterol cyst or proteinaceous debris. However, interestingly, at surgery, only cholesterol granuloma was found. So this, for us, raised the question of, we assume when we see decreased diffusivity that is pathognomonic for cholesteatoma, but do any members of the audience see decreased diffusivity ever as a manifestation of cholesterol granuloma, or perhaps this was a little inspissated proteinaceous debris adjacent to the cholesterol granuloma? Lastly, a patient who, with the same history, had an MR for recurrent cholesteatoma. Once again, we saw decreased diffusivity and a rounded opacity in the attic over here concerning for recurrence. We weren't particularly worried about the mastoid bowl. And interestingly, on T2 space images, this lesion had low signal essentially and a bright rim of high signal intensity surrounding that. And so we were intrigued by the findings, again, courtesy of Dr. Dennis Poe, where he said at surgery when he opened the external cyst, he got a kind of brake fluid-like material pouring out. And so this was diagnosed then as a cholesterol granuloma, within the center of which the second white encapsulated focus turned out to be recurrent cholesteatoma. So a rather unusual case of cholesteatoma nestled inside a cholesterol cyst as recurrent disease. So thank you all very much. And that is my cases. And there are some questions here. Somebody said they had problems hearing me. I'm so sorry. I hope it wasn't too much of a problem. And hope I haven't been on mute this whole time. Nope. Are there any other questions before we close off? So Dr. Defoe says we rely on the 1000 ADC max, unenhanced T1. When high on T1, it is not a cholesteatoma. Absolutely agree. That lesion we described as being both cholesterol granuloma and cholesteatoma, but somehow in surgery, only cholesterol granuloma was found. Great. Well, thank you all so much for joining us. Any other questions or comments from our panelists?
No, it was great, and we were not coordinated, but we spoke about similar topics. It was amazing. So you think that my can be a gallstone?
I do think it could be a lymphatic malformation. So we've had 3 now, all of which looked pretty much the same. And the key feature in 2 of them was, and I forgot to mention that, demineralization of the head of the malleus. One of them was actually confirmed in biopsy as dysplastic lymphatic channel. So it was a definite case of LM and it was read out as Gorham-Stark disease. The other 2 we felt were actually very similar. So my presumption would be that these are cases of an underlying low flow vascular anomaly that leads to weakened bone, CSF leak. We've also got a number of cases of proven venous malformations, you know, the ones that are multiple. So, for example, the blue rubber bed nevus syndrome, those types of multiple venous malformations that have been associated with CSF leaks and intracranial hypotension. So it's important to recognize that these injuries can also involve the temporal bone and surrounding tissues.
I think it's interesting comparing our cases. The histology from ours showed scattered lymphocytes and plasma cells in keeping with a chronic inflammatory process, which I think really made us much more confident that it was a chronic picture of an osteomyelitis. There's no signs of lymphatics and so on. So, but I think it's very interesting how 2 cases which are quite similar, although obviously yours have much more dramatic involvement of the carotid, can potentially represent different processes.
Yes, very, very interesting. And then the question is, given that lymphatic malformations, you know, one of the common complications is infection. The question is, how confident were the pathologists that there was absolutely no lymphoid material in the specimen? And, you know, it's kind of, that's why I showed the chicken or the egg. It's kind of hard to know which came first.
I think also, well, certainly the lymphatic malformations that we see, obviously we see lots and lots of lymphatic malformations in the neck, and they certainly have a propensity to get infected and swell with infection, but purely intraosseous lymphatic malformations, I think obviously we've got much less experience on, and whether or not they present with recurrent periauricular swelling is, I don't know. I've got much less experience with them.
Yeah, fascinating. Thank you so much for joining us, by the way. It really enriches our learning to have you with us. So I hope you'll consider joining us again.
It was very nice.
Thank you very much. Thank you, Dr. Nash.
All right. Thanks, everybody.
Thank you.